say e-tracker, next slide please, we say actually you all understand DHIS2. It is an application built in DHIS2. And of course, next slide. Next slide. The e-tracker is an application built in DHIS2. And as you all know, DHIS2 has been adopted 2012. And since we have been using this DHIS2, then in 2019, if I'm not mistaken, this is where now this e-tracker has been adopted. So why e-tracker? E-tracker is there to help because it records the transactional individual data. So it is there to help improve the immunization service delivery. And why are we evaluating this? We're evaluating this because we wanted to generate an evidence, not only for Rwanda, but also for low and middle income countries who seek to implement such a tool, as well as discussing the electronic immunization in advancing healthcare delivery in general. And our method, actually, this was a mixed method, including the time series analysis, but of course, we surveyed and quantified as well as qualitative studies, and we sampled conveniently 24 health facilities, health centers, and 12 district hospitals. These are the facilities where we conducted quantitative and qualitative study. Next slide. And in this study, we've seen main implementation strength. Yes, this was implemented in all 505 health centers. We ran this evaluation back in 2022. It was January, February, and March. And yeah, the e-tracker was being used in 505 health centers, as well as 10 private health facilities. So the main implementation, it was implemented in September 2019, as I mentioned. And of course, the implementation took around 4 months. And this e-tracker was implemented envisioning the interoperability with other existing health systems, as well as the CRVS. And at the health center, we realized that they were using the e-tracker to record the data, after which the data manager would enter in the system. At the district hospital, the API supervisors were using this to monitor the overall immunization at the catchment area, while here at the RBC, at the central level, this is where the e-tracker belongs. Of course, you do all to make sure the e-tracker is working well. So I was saying we saw the main implementation strength. Next slide, please. In this, of where there was a strong political will with the existing experience using digitalization tools, as well as the perception of user-friendliness of the tool from the users, the availability of IT support, interoperability with other systems. But here, when we conducted this study, there was no interoperability with CRVS, but also it was good to have this e-tracker implemented nationwide, which would do easy for the central level, I think, for the monitoring and support. So when we go in the findings, we first classified the users in frequent users and non-frequent users, as well as the rural and urban users. When I say rural and urban users, we based on the existing structure of health centers, while on the frequent and non-frequent users, we classified based on the data collected in the survey. So we realized that frequent and rural users were having better perception of the computer literacy, of the quality of the information, of the e-tracker. And can you go next slide, please? Yes, I was saying that the rural and frequent users were having the better perception regarding the use of e-tracker, whereby they were having a good perception of their own computer literacy, the quality of the information in e-tracker, the availability of IT support, as well as the overall increased user satisfaction. However, better infrastructure, I mean IT and internet connectivity, as well as electricity, we realized that they were having good impact on the use of e-tracker. When we look at the tool functionality, and we realized that at health center, the in charge of immunization, next slide please. The in charge of immunization at health center, we are using specifically the e-tracker for forecasting the vaccines, as well as planning for the outreach. While at the hospital, at the district hospital, the API supervisors were using this for monitoring the program in general, as previously mentioned, as well as adjusting supervision visits. We saw that around 50% from both facilities trusted the tracker, saying that the information would be available anytime. While around the half of the health facilities we interviewed and the DH staff, they thought they could finish their task faster, but they were having a burden of first completing the registers as well as entering the data in the e-tracker. Thus, it was sought as a burden to them because of doing the work in double. So generally, at health center, they were saying that e-tracker would help them speed up their work. Next slide, please. When we look at the data quality, in terms of data quality, it is surprisingly that more than 75% were still at health center, were still hoping that the good source of data is paper or registers, the existing registers. And when we look at the improving data quality, around half or at the health center and around 60% at the district hospital staff interviewed, they said that this tracker would help them improve their data. And regarding the accuracy at health center, only 25% were seeing this as improving the data accuracy, while at district hospital, more of the district hospital and the frequent users were hoping that the tool would help them to increase the completeness of data. So when we try to compare the rural and the frequent user, as I mentioned, most of them, they were hoping that this e-tracker will increase, will reduce their work and will increase the data accuracy, while the urban and the urban users were seeing no difference of using both. So next slide, please. When you look at the impact on data use, regarding the target population, here I mean to get the denominator, there was no interoperability by that time with the CRVS, which would actually solve the issue of the denominator. And of course, the defaulter tracking and the tracking of dropout rates was not yet impacted by that time, as you can see with the numbers, with figures. But only supervision activities at the health center were being impacted at that time. We go next slide. When we look at affordability and sustainability of the tool, not only in Rwanda, but here we tried to simulate But before that, we saw 79% increase in terms of cost annually, as you can see from the figures on the right. However, when we tried to make a simulation, if we no, it is here. I don't know. Sorry a bit.
It seems people online.
It is on.
People, there's no sound online.
Should I hold in like this? Okay, no problem. No problem. I will make it like this. I was saying that when we try to look at affordability in terms of money, we realized a 79 increase because of doing paperwork as at the same time with the e-tracker. So you can tell it was a burden to staff at health centers, and